It's a challenge sometimes to quickly build trust and take care of families in their stressful moments, especially in the middle of the night when they've just woken up with their very sick child and carted them off to the hospital.
Hi, this is Unlimited Access. My name is Levi.
Hi, I'm Shannon Aylesworth.
Hi, I'm Dr. Laura Cardello.
Dr. Laura Cardello. Now, can we say Laura during the show today?
That would be great.
Okay, so Laura, thank you so much for joining us. And why don't you just give us a quick, brief introduction about who you are?
Sure. So I am a pediatric hospitalist in Massachusetts, and that means that I take care of pediatric patients only in the hospital. So I work full time with sick patients that are admitted to the hospital and all of the newborn babies that are born each day. And I've been doing that for almost 20 years now.
Did you start in that, or did you have a previous history, or have you always been in pediatric?
So I've always been in pediatrics. So I started my training in my pediatric training in Connecticut at Connecticut Children's Medical Center, and I worked for 1 year in primary care while I was in Connecticut. When I moved back home to Massachusetts, I started working as a hospitalist in a small community hospital, and then transitioned over to Boston Children's Hospital, where I work now in one of their community network hospital sites.
Did you always want to be in a hospital, or was it just a natural transition of your career?
I did always want to be in a hospital. I did 1 year of primary care while I was waiting for my husband to finish his training because he's also a pediatric hospitalist. And I just knew that my training was built for hospital medicine, that I knew how to take care of sick patients, and that was where I really wanted to be.
Wait,
Cool.
I'm going to be the ignorant person here. I didn't realize, I know there's a difference between a hospital and like where my primary care doctor is, but what is the difference in your world, Laura?
So I take care of patients just for a small snapshot in time. They come to me from the emergency room when they need to spend time in the hospital, but I don't take care of them in the office. I don't do well child checkups in the office and see them longitudinally. I just see patients when they're acutely sick and make them better and send them back home to their primary care doctors.
That it seems so obvious, but I actually, until the two of you just said it that way, I never thought about it that way. So you're a pediatrician, right? And when kids get sick, I'm a father of three children myself. It's just really hard. And can you just walk us through that process when children get sick and nobody plans for how to care for them? Can you just walk us through that process from like the time maybe they get involved and when you get a chance to see them?
Yeah, I think you're right. That's a really stressful time for families. I think for adults, we think of illness more chronic and that things build and gradually patients get sicker over time based on their age or their underlying medical conditions. But most of the time for children, illness comes suddenly and quickly. And it can be just an acute illness like a fever or pneumonia, or it can even be the first presentation of a child with diabetes or childhood cancers, and they usually were previously very healthy kids who were suddenly sick. So that's a really stressful time for families. The place that I interact with the families first is that they are sent to me from their primary care doctors for care and for further diagnostic workup. And I meet families in their most stressful time, and I don't have the luxury of having a long relationship with them like their primary care doctors do. So it's a challenge sometimes to quickly build trust and take care of families when they're in their stressful moments, especially in the middle of the night when they've just woken up with their very sick child and carted them off to the hospital.
Oh, and at that point, they've gone through the ER probably already, and then they get admitted, and now you've got to quickly get that. Do the do a lot of the kids come in with? Do they have multiple issues? Is it you mentioned the primary care, but do they have specialists, or is it really the primary care pediatrician that deals with the child through the whole process versus an older person who has 12 doctors?
Yeah, I would say for the most part, most children are generally healthy and are cared for by their primary care physician, but there are certainly a subset of patients with chronic diseases that have specialists and sometimes multiple specialists. So those can be also challenging in a community hospital setting where I don't have access to their specialists all the time. Those are usually in the bigger tertiary care centers like Boston Children's.
Yeah, I think what's interesting, like, that was a bit of a leading question because I was like, it's not like people like to say, "Oh, the older population," and I'm like, that's where you were like, "The younger population." Listen, it's still happening. Is it happening as prevalently, at least the multiple chronic conditions now that children and I wanna lean into that point that you made about what time they come in. But with the older patients, right, everybody goes, "Oh, it's the older population." I'm like, "Don't be fooled. It is more and more often it's younger children, and really they're in for some extreme diagnosis, but there are 3 other things going on that we didn't have before. Most of that's from food and all that other stuff, but that they didn't have, and that it is becoming more prevalent. So in the geriatric, right, they got 12 to 14, it was always like, well, kids usually only have 1. That's not necessarily the case anymore. So it sounds like that problem for you where not even having the information on the patient child, but now you've got multiple specialists who, especially in a rural community or something that's a little bit less urban, where everything's in one location.
Yeah, that's right. And I think if you're talking about an adult with cardiovascular disease, they may have a specialist in Boston, but the cardiologists at my community hospital, the adult cardiologists, be perfectly capable of taking care of them during an acute illness. We don't have that luxury in pediatrics. If I have a patient who had heart surgery and they're coming in for pneumonia, I often have to transfer them over to where their specialists are because I don't have a pediatric cardiologist that can help us take care of them when they're sick.
And then one other thing you said, I'm sorry, Levi, you wanna go? You wanna go?
What I was thinking about is this a child in communication. Obviously, the younger the child is, maybe even the older, it's hard to actually, they don't communicate really well, do they? Or maybe they do, and they don't bring a lot of baggage of like self diagnosis either. So I don't know. What's that like?
You're right. If we run the gamut from nonverbal all the way to teens of all variety, sometimes we are dealing with sort of a much more mature adult type teenager, and sometimes we're dealing with a completely closed door. And we rely a lot on the parents, of course. But
It's like my son, my youngest is 12, right? And he remembers a couple of things about his health, but he probably doesn't remember much about it. And I'm thinking about if I were to take my son into the hospital for an acute thing, my wife is out of town right now, for example. I really don't know anything other than I have to feed him breakfast in the morning. And my wife has this medical history that of every single minor injury that he's ever had. And my son, who's 12, doesn't know this. That communication has also gotta be really a challenge as you're trying to diagnose and trying to get this information. If the parent doesn't have it, the child can't communicate it either really well, right?
that's true. And I think that's it brings up a couple challenges. A lot of times there are two caregivers in the house and they don't both all have the same information, especially in an acute illness. There's discussion about, I don't really remember which day this started and that symptom started and the back and forth of that. But there's also parents are usually generally pretty good about remembering medicines that their children have been on for long periods of time. So, a diabetic and their insulin regimen, for example, that's something the parents come in and they know. But what my child was prescribed last week when they started to get an ear infection, they usually are telling me, I don't remember the name of it. And I have to guess based on the smell, the color, or the flavor. Because they'll tell me things like, it was the pink bubblegum one. And then they switched it to a white one.
Oh my god.
And this is how I have to figure out what medicines the children are on.
Yeah,
Yeah.
I'd be guilty. That would be me. It's like a pink thing he takes. I don't know.
I still do it. I just said to another I don't remember who it was, but I go, "Listen, I know you can." Oh, he's in ortho. And he was talking about an NSAID, but I go, "I gotta be honest with you, when you say," or he was talking to anti-inflammatory, I said, "I still, to this day, don't call Tylenol an anti-inflammatory." This goes back to Dr. Laura, what we said early on is like, doctors' communication and patient communication, it should be like Spanish to English. There's gotta be a translator that said because I'm like, I still don't know whether Motrin is an anti-inflammatory or not, or Tylenol is. And doctors will say, take an anti-inflammatory. I'm like, you know why I know now? Because I have horses. Because I know and I have dogs who have knee issues. So now I know. And even then I'm like, I think it's gabapentin and I think that's a nerve thing. So I think that's a really important point I hadn't thought about, which like you to your point, you're like, it's pink, it's white, and then you're
Right.
guessing.
And they came to
And
the emergency
that's
room
huge because
with
there's so many
I was gonna say that to compound that, they pack everything up and come into the emergency room quickly. They didn't think to bring all the medicines or take pictures of all of that beforehand. These are things their kid usually isn't on. So it's hard.
We gotta clip that, Levi, because that I hadn't even thought about that, just the medication. So we had talked about, right, about and again, middle of the night. So just elaborate on that piece. So not only are these kids sick, the parents are probably panicky. Nobody thought, let me grab the medicine as I run in to find out. And then you try to collect all this information. And what's the normal time that you can get people to respond?
To,
9 to
to
5. 9
yeah,
to 5 to records, right? If you need that information and they're coming in the middle of the night, how are you gonna get access to that data?
I don't have access till the next morning. So it's unless I have some access into the silo of their primary care office, but it usually relies on archaic things like picking up the phone or getting a fax or
Yeah, it seems to me like every trip my child took to the emergency room happened when the primary care office is closed anyway. So it's like you don't even have any of the information. So you're panicking as a parent, right? Because your child is sick, they're not communicating really well. That fever always happens late at night for whatever reason, and you're heading to the emergency room or you're heading to the whatever the clinic, whatever those things are, the urgent care, and you just can't think straight, and you don't have all the information, and it's just out there. So one of the things we wrote down for the show, one of the notes we were was children. Nobody really wants to get poked a million times or 10,000 times, and it seems to me like this lack of information basically forces you as a physician, and you can clarify to basically, I'm gonna say not over medicate, but over diagnose because they're like, just to be cautious, you could have a rabies thing. So we're gonna give you the rabies. I'm exaggerating, of course, but can you elaborate on that? Because it's like if you don't have all the information, your obligation is to get them healthy and you're gonna have to overpoke. Is there a good way to say that?
yeah, I think that's absolutely right, especially in the field that I'm in, where as I described before, I'm just seeing this patient probably for the first time I've ever met them. So this is for me a snapshot in time, but they're coming in with a complaint that might have 5 or 6 different possible diagnoses that I need to navigate and figure and rule out the big ones and figure out what's actually going on. And a lot of times previous medical records would have helped me rule out some of those things, whether I had blood work from the last time that patient was in the office, or if they do have chronic illnesses, maybe a diabetic, what is their blood sugar like usually? And how are they presenting to me now? So those kinds of things we do often end up repeating tests that were done at other offices or even tests that were done at urgent care centers that I don't have access to, particularly x-rays. I won't be able to see them until the morning, but I need to know now, so I'm gonna have to repeat it.
I I just wrote something down because I just had another one of those light bulbs. So I always have questions and then I start taking it a little sideways. I just got thinking, so you not only do you have to run the test again, and I think what you told me is like, you got to poke the kid again, which again, adults, we don't like, hey, here's another vein. Kid, like, come on. And you don't, and they're sick and they feel terrible. And moms are probably like, why can't you get the data? But then I thought, if you can't get it till the morning, how many times is my primary care late to my appointment because he has to respond to emergent situations of sending records and making sure this stuff gets back to the hospital to
Mhm.
take care of their patient? And I remember, right? I think about how many times I take the 8 o'clock appointment because I'm not going to be that late. And the doctor notoriously walks in at 9 o'clock. Sorry, I'm late. And you're like, how?
Oh,
First point in the morning. Can you be late? And you're like, oh, because they're responding to all of this stuff. And that's not an intentional lack of operability. That is just you cannot set up a system to respond 24 hours. That's why having that patient and giving the parents a tool
yeah.
and giving them a tool because kids can't fill out like they can't fill out their own meds. So how do we make that easy on them
Mhm.
and make that experience a little bit easier? So there's no question in there. I just was like, oh my god, that's why my primary care can't get in on time. You're like, it's just this amazing backup of data flow. That's why we say data flow. It's not. It's data flow. It's all right. I'm done.
That was
Levi, but,
and,
every time I talk to you, Laura, I get another insight. I'm like,
yeah, and the primary care doctors would love it if they didn't have to spend their time for the first hour of their day going through what they
my
call the inbox of their EMR.
You gave me a survey question that I'm going to ask all of our primary cares. How much time in the morning do you spend responding to responses at the hospitals.
Mhm.
And if that answer is anything more than an hour, that's ridiculous.
We're talking a lot about this data flow, all this information that's out there and the communication between the two. Have you had any scenarios in the last week, Laura, that you're like, hey, here's an example. Let me show you how this could have been better.
Yeah, absolutely. I think last week is a great example. Last week was Thanksgiving. So families were traveling across the country. So I took care of a patient who had gotten sick while they were away in New York over the Thanksgiving break. They had seen a doctor in an urgent care center, and they had also been to an emergency room in New York. They had lab tests, they had x rays, and they were given a prescription and sent home. And they made it home, their drive home, but the child got sicker and came into my hospital through the emergency room. And then it was up to me to try to figure out now what happened in New York between these two healthcare points of connection that the family had, and now they've come to me for answers and to make their child better.
Levi, go.
I muted myself in between.
Oh,
The
sorry. Where I was gonna do a follow-up, but my thing kept popping up, "Do you wanna unmute your phone?" So I usually would throw a question in there, and I got more distracted.
Well, I think you were
Now.
typing notes, and so I muted you while you were typing your notes.
Oh, I was. I'm
See,
sorry. I was
right?
asking that question you just did, yeah.
It's like this magic. I have these hands that are down here that you can't see, that I'm over here just magically controlling a lot of these things. So I was like, "Oh, she's typing notes. Let me mute her mic."
I
And then you were
was,
unmuting
sorry.
it, and I was trying to mute it, and Dr. Laura had this really good thing. But so,
It said Levi asked you to unmute. That's why I was like, "Okay, I'll unmute it."
yeah, but no, it's like, yeah, I didn't even think about that. You're right, because we were talking about this with Julie a few weeks ago, and it's like when we're traveling, I definitely don't have all of my stuff. So if I'm traveling for Thanksgiving and all of a sudden an emergency takes place and now I'm in this hospital, which I don't know anybody here, I don't have any of my information with me. And so the child is lacking information and the ability to communicate. The parent is freaking out, lack of ability to communicate. And you're trying to get some basic, probably information that's would be easily, readily accessible in most other things of life. But for whatever reason, in the medical world, in the hospital world, you're just flying blind and you're becoming like this sleuth trying to discover and understand everything.
Yeah. And I want to put my eyes on that x-ray that child had. If they're coming to me with breathing trouble, I want to see that x-ray and not have to repeat it now that the child's in front of me. That would have been very easy for me to see it, but I don't have access to medical records in New York. I think that brings up it's why I love what you guys are doing here is that the whole idea of electronic medical records, they all came up in silos, and every hospital has their own record system, and every primary care office has a different record system. And I think in the past, people have tried to think about this problem and solve it by trying to connect all the silos to each other, which is nearly impossible, right? And the combination of places I could go for care is just infinite. So which ones do you connect first, or how do you connect them all? But I think what you guys have done is take this completely different approach and put the records back in the patient's hand so that they are walking around with a mobile file cabinet of their own records. Now it doesn't matter which place they went to. They just have it all.
This is really interesting. I'm going to share a little story, Shannon, real quickly. But Dr. Laura, I keep calling you Dr. Laura because I saw the emails. But Laura, I was in the military when I was a young guy and I joined when I was 21. And as a military person, you get assignments, right? And you would go from one place to the next, one place to the next. And we would always have to, before we would move from one place to the next, we would always have to go to the hospital, the local clinic at our base, grab our records, and they put them in these sealed things as if I'm not supposed to read them or whatever. But we would get these sealed records. And I would take my medical records, my important files or whatever as a military guy, and I would actually have to hand carry them to my next place. And this is obviously in the early 90s, pre-internet. But yeah, but I owned my records to some extent. I had them in my physical possession. Now I would go to the next clinic and I would drop them off. But it seems to me like this is like a modern problem to some extent because it's like now everything's digital, but nobody's able to see everything digital. Whereas if patients had their own records in their possession, it would be just so much simpler. You could just give it to me and you would just have it, right?
Right. Yep.
Well, and the good news though, Levi, is here's what happened, is you wouldn't, as Laura said, they're trying to connect all these silos, which is there's an unending amount of permutation. And then medicine is a science, it's an art. I believe it's an art
Mhm.
form. I believe technology and medicine are two opposites of the same coin, by the way, because it's about putting that together and then figuring out the science behind it. And Laura looking at an x-ray might come up with a different result than somebody else. Or even within 3 days, you might see something different, and even being able to compare, even if she does take an x-ray today, there may have been one a week ago, and there's something that the difference will tell you what's going on, and I learned that firsthand with my mom. But the fear that caused this from being not happening was because it was patients are gonna get their records, and they're gonna panic.
Hmm.
So, that's where we're like, "Listen, this, overabundance of caution of scaring the patients, it's already done, man, just Google." Just Google, "You're dying in 6 months, no matter what."
Yeah.
So it's really about, and that's what I love what you say, and you've been with us since the beginning, Laura. You're like, give the patient the data so that as they move, and really educating us on making sure that the patients have education. And I talked to a doctor from Sloan last week, and he said, "Listen, we're just pushing cancer diagnosis out there. There's nothing going with it. There's no education, there's no virtual hug, there's not,
Mhm.
it might not be like, again, prostate cancer. You guys like, everybody goes, "Yeah, no, it happens." Oh, okay, that would be great if you sent me a note that had some stats when that popped up, you know what I'm saying? That kind of thing. He was like, "If you can do that, we have no filter on the data that we push right now." So that's
Mm.
the other thing that we really learned how to do is filter the data, understand who's in an acute and probably needs a call or whatever. So as we get this noise out, because patients are able to give that data quickly as they move through the system. So
Mhm.
I love what you say there. I love the fact that you highlight the difference, and I love we did the drawing together. It was like, just push the data in that direction, add some education, add some resources, there's so many people out there now to help us as patients understand that. Levi, God love him, wouldn't look at him. He'd just walk around and be like, "Here's my app." So
Yeah.
we like patients like him. Here you go. You're harmless.
Yeah.
Yeah. I have one final question, Laura, is this I think about your job, and I know the times again when my children have been in the ER and stuff like that, and it's just scary. And, it has to take a lot of courage to do what you do. It has to take a lot of fortitude to deal with children in these dire moments and deal with parents or whoever else in those dire moments too, right? The parent freaking out. But it seems to me like your job would be better I don't know, maybe you tell me, would you rather spend your time dealing with paperwork or dealing with the patient? Is this the whole goal is to free you up to spend those times and those emotional moments help?
Yeah, you're absolutely right. I think on any given day, I spend more than 50%, maybe even 70% of my time in front of the computer screen, not in front of the patient, just trying to document in the records or get records or communicate with other specialists or physicians. The screen time is predominant part of my workday and would rather it not be.
Yeah. I think that's interesting to hear as a hospitalist when you're probably dealing with the most urgent of cases, the fact that you're still spending that amount of time. I guess my follow on question would be like, how much time do you think you could spend with more patients if you didn't have to do that? Do you feel like half the day or whatever? And you're like, "Listen, if it's half the time you're there, 5 hours, 4 hours, that's 4 hours times X amount of patients. That's simple math." Do you have thought on that? Like how much time you could save and put to the patients? Or maybe spending more time with each patient, like we had talked about that book where you're like, you don't spend enough time with the patient.
Yeah, I think I would love to have more time with each patient for sure, to do that education, to build that relationship, to build that trust, and
Mhm.
especially talked a little bit earlier about taking care of all the newborns in the nursery. And those are often they're brand new parents. They just made a whole new person from scratch. And I'm walking in there and I've got 10 minutes to spend with them and the another 20 minutes to document or even a good 20 minutes just reviewing the prenatal records before I go in the room. I think
That's
spending more
amazing.
time with patients would be ideal.
Okay.
Yeah, it's almost if I were to break it up into thirds, it sounds to me like 2/3 of your time is spent doing the non-work that you really wanna do, and you're only getting 1/3 of the time to really spend time with the parent or the patient, I should say.
Yeah, I'd say that's accurate. I would say it takes about a third to gather the data, and then a third on the back end to document what I did and what I said and my thoughts on the patient.
Could you imagine a parent who said, "I choose this hospital because Dr. Laura is there"? I'm just saying. Like, how many people you don't know what hospital you're going to, you'd be like, "Listen, that I see her, you're saying it's that trust, it's that commitment, it's that understanding that you've taken the time to understand what they're going through." That's kind of amazing, and I know I'd be like, "I wanna go to that hospital." Who wants to say that? But loyalty, patient loyalty.
It's one of those things where it's like, I want these shows before the show, I'm always like, "Okay, guys, let's keep it really tight. We don't wanna have a 2-hour-long show." But then as we start to talk and listen to like, "Let's make it a 2-hour
I'm looking at
show."
the I'm like, 28. Dang, we did not do and that was a lot on me. Oh, yeah.
Oh, no, it's really good. The thing is, it's a big, complex system and a big, complex problem, and we're just one piece of this to hopefully help people like you, Laura, do your job better and give you more time to spend time with the patient. I did learn one thing, and I'll wrap here with this, but I learned the term hospitalist. Is that what you said?
Yeah, that's right.
Every show, I learn another medical term. One day, I'm gonna be MD Spires because I'm gonna have all these
Well,
terms
listen,
down.
that's why we have to have a section. I realized that the other day. It's like, why is it so important that you understand a hospitalist and asking Dr. Laura about your splinter or whatever is very different from what she does, and especially based on where she does it. And like I was just saying that about primary, there's 5 different specialties, 5, and there's some unique thing. My point, we got to do more education of ourselves, quite frankly, and
Yeah,
patients in general.
education of Levi.
Right.
Well, Laura, thank you so much for joining us today. Pleasure having you on the podcast.
Yeah, that was great. Thanks for having me. It was nice to talk to you.
Thank you.
Here at Ursamin, we believe people, patients, caregivers, everyone will make better health decisions if they have access to all of the right information, if the patient actually owned their own data. So that's what we're working toward. Thank you so much for listening, and bye. I appreciate it. Bye.